You know, back in 1644, Evangelista Torricelli, he's the brilliant mind who invented the barometer, he wrote this letter with a really profound realization in it.
Oh, the ocean of air quote, right.
Exactly, yeah. He said, "We lives submerged at the bottom of an ocean of the element air." And it's a beautiful image, but I think it completely obscures how incredibly fragile our biology is.
Yeah, we take the pressure at the bottom of that ocean completely for granted.
We really do. Because today for our deep dive, we are exploring what happens when you decide to leave the safety of the bottom and travel to the shallowest, most dangerous parts of that ocean.
And, to understand just how violently the human body reacts to that environment, we actually have to look back at what happened during the ballooning craze of the 19th century.
Oh, the Zenith flight, right, in 1875.
That's the one. So, 3 French aeronauts ascended into the atmosphere in a balloon called the Zenith. But only one of them, a guy named Gaston Tissandier, actually survived to write the report.
And his account is it's terrifying. He described this overwhelming sense of inner joy and this creeping numbness.
Right, like a total euphoria.
Yeah, he realized he was in mortal danger. You know, he knew he needed to grab his oxygen tube, but he literally, physically couldn't raise his arm.
He was paralyzed by it.
Completely. And yet he felt absolutely no pain before passing out. His 2 companions, Crochet Spinelli and Civil, they died right there in the basket from severe acute hypoxia.
It is a phenomenal, albeit, really tragic historical starting point for our deep dive today because we are unpacking the definitive playbook on high-altitude medicine.
Ward, Millage, and West's textbook, right?
Yes, specifically the newly updated Ward, Millage, and West High-Altitude Medicine and Physiology, 6th edition. The goal here is to really figure out exactly what happens when you push the human body past its limits, how it tries to adapt, and what clinical chaos erupts when those adaptations just fail.
Okay, let's unpack this because I want to stick with that balloon flight for a second. I feel like there is a massive misconception here. Well, when we think of suffocating or running out of air, we think of sheer panic, right? We think of thrashing around, gasping, just this primal fear of death.
Right, the instinct to fight.
Exactly. So why didn't Tissandier and his crew feel like they were suffocating? I mean, his description sounds almost exactly like the painless, euphoric descent into unconsciousness that you see with, like, carbon monoxide poisoning.
Yeah, it's very similar.
Why doesn't the brain trigger an absolute red alert panic response when oxygen levels plummet to a lethal low?
What's fascinating here is that your brain is essentially looking at the wrong gauge on the dashboard.
The wrong gauge.
Yeah, it fundamentally comes down to how our respiratory drive is wired.
Yeah.
The human drive to breathe, that desperate, agonizing feeling of suffocation when you hold your breath underwater, that is primarily triggered by an accumulation of carbon dioxide in your blood.
Oh, not a drop in oxygen.
Right, not the lack of oxygen. The chemoreceptors in your brainstem, they're highly sensitive to acidic changes caused by CO2. But in a balloon at high altitude, or, standing on a mountain peak, there's no barrier to exhalation.
You're still breathing out perfectly fine.
Exactly. You are still successfully blowing off carbon dioxide into the thin atmosphere. In fact, your CO2 levels might actually drop below normal because the thin air is making you breathe a bit faster.
So the brain's primary alarm bell for suffocation it never rings.
Never rings. The carbon dioxide gauge looks perfectly fine, so the brain just assumes everything is okay, even as the oxygen levels in your blood plummet to lethal lows.
You just peacefully, happily fade away.
Yeah. And the exact mechanism of this hostile environment, it actually wasn't truly proven until 1878 when the father of modern high-altitude physiology, Paul Bert, published his landmark book, La Pression barométrique.
And he didn't just climb a mountain to figure this out, right? He actually built controlled environments to isolate the variables.
He did. Because back then, they didn't know if the sickness was caused by the cold or, the physical lack of atmospheric weight pressing on the body, or if it was the air itself.
Right.
So he used both hyperbaric chambers, which physically suck the air out to simulate low barometric pressure, and normobaric chambers.
Wait, normobaric, meaning normal pressure.
Exactly. Normal pressure. The physical weight on the body is kept at normal sea level levels, but the oxygen concentration is artificially lowered by pumping in other gases.
Ah, clever.
Very. And through these experiments, he proved that the true culprit of altitude sickness isn't the mechanical lack of pressure crushing you or expanding your tissues. It is strictly the low partial pressure of oxygen, or PO2.
Okay, let me make sure I'm picturing this correctly. The air is still roughly 21% oxygen, whether you are on the beach in Miami or on the summit of Everest.
Yes, the fraction of oxygen doesn't change.
But because the barometric pressure is lower up high, the air molecules are just spread much further apart. It's like a room with the exact same ratio of men to women, but the room itself is 10 times larger and there is just far fewer people overall. There is simply a scarcity of oxygen molecules available to physically cross over into the blood inside your lungs.
That is a perfect way to visualize it. So knowing that a drop in the partial pressure of oxygen is the absolute trigger, we have to ask how a healthy human body compensates.
Because clearly, humans do survive up there.
They do. When you are acutely exposed to high altitude, your body's immediate emergency response is to heavily increase cardiac output. It goes up by approximately 50%.
Here's where it gets really interesting. 50%. That sounds incredibly taxing.
It's a massive workload.
Yeah, if my resting heart rate goes from, say, 60 to 90 beats per minute just sitting in a tent, isn't that a massive metabolic drain? I mean, you can't just run your car engine in the red zone indefinitely.
You can't, and the body knows that. To maintain what we call convective oxygen delivery, which basically means keeping the same total amount of oxygen flowing to your brain and organs, despite the blood itself holding less of it, your heart rate and your stroke volume just spike.
But it's temporary.
Exactly. That massive cardiac surge is just a temporary physiological bridge. It's an emergency measure to keep you alive while the slower, much more efficient long-term adaptations take over.
What do those look like?
Well, over the following days and weeks, the body initiates this fascinating sequence of events. First, your plasma volume actually decreases.
Wait, so the liquid part of your blood just drops? Why would getting dehydrated help?
Well, it's not dehydration in the sense of losing water you need. It's a targeted reduction in fluid to concentrate the blood. Think of it like a soup. If you have a soup that isn't flavorful enough, you boil off some of the water to concentrate the ingredients.
Oh, I see.
By reducing plasma volume, the concentration of red blood cells per deciliter goes up immediately.
So you're instantly packing more oxygen carriers into a smaller volume.
Exactly. Then the real heavy lifting begins. Your kidneys sense the low oxygen and they ramp up the production of a hormone called erythropoietin, or EPO.
Like the doping drug in cycling.
Yes, exactly like that, but your body makes it naturally. That EPO stimulates your bone marrow to physically manufacture new red blood cells, which increases your total red cell mass.
Wow.
And as your total hemoglobin concentration rises, your blood can physically carry a much larger payload of oxygen. Once that slower process completes, the emergency is over, and your cardiac output can safely return to baseline sea level values.
It's an incredible piece of biological engineering. You build more delivery trucks so you don't have to drive the existing ones quite so fast.
That's a great analogy.
But as the textbook points out, there is a hard mathematical limit to this engineering. If you go high enough into what mountaineers grimly refer to as the death zone, usually above 8,000 meters, acclimatization entirely fails.
It just shuts down.
The delivery trucks just can't find enough cargo.
Right. At that extreme altitude, the partial pressure of oxygen is so profoundly low that literally no amount of extra hemoglobin can compensate for the deficit.
You just hit a wall.
You cross a physiological threshold where adaptation stops entirely, and you enter a state of high-altitude deterioration.
And the sources describe that deterioration in really visceral terms. I mean, it's not just feeling out of breath. It is severe anorexia, dramatic weight loss, intense lethargy, impaired cognitive function.
Yes, and this profound, inescapable inability to recover from fatigue.
Right. You lose the willpower to even start new tasks. It sounds like the body is literally consuming itself just to keep the brain and heart faintly ticking.
That is precisely what is happening. The metabolic cost of digestion just becomes too high, so your appetite vanishes. The body begins breaking down its own muscle tissue for energy.
But that physiological bridge we talked about earlier, the racing heart waiting for the new red blood cells, that eventually collapses for some people long before they ever reach the death zone.
Unfortunately, yes.
When the heart and the blood can't keep up with the oxygen demand at normal tourist or trekking altitudes, the body doesn't just quietly fail. It starts actively breaking down.
Which leads us to what you'll actually see if you are a clinician working in a mountain clinic. We have to talk about the big three acute altitude illnesses.
Let's get into those.
So the first, and by far the most common, is acute mountain weakness, or AMS. If you are treating patients in a ski resort clinic or, say, a high-altitude base camp, this is going to be your bread and butter.
What are the main symptoms?
The cardinal feature of AMS is a bilateral, throbbing headache. It is almost universally worse in the morning, and it severely worsens with any Valsalva maneuvers,
Valsalva meaning?
meaning anything that briefly increases pressure in the chest or head.
Hmm.
So coughing, bearing down, or even just bending over to tie a boot.
Oh, wow. Just tying your shoe causes a spike in pain.
Exactly. And this headache is accompanied by systemic, almost hangover-like symptoms. So you'll see loss of appetite, nausea, vomiting, and profound fatigue.
I always hear that for most people, if they just stop going higher and rest, AMS resolves on its own in 1 to 4 days. The body just needs time for that EPO and red blood cell production to catch up.
That's usually the case, yes.
But what if they need pharmacologic help? Because the textbook highlights a drug called acetazolamide to prevent or treat this. How exactly does a pill speed up acclimatization?
Acetazolamide is super interesting. It works by essentially tricking the brain into breathing more effectively, especially while you're sleeping.
Herkiat, how?
Physiologically, it acts on the kidneys, forcing them to excrete bicarbonate in the urine. Bicarbonate is a base, so when you pee it out, your blood becomes slightly more acidic, a state called metabolic acidosis.
Ah, and earlier we said the brain's breathing sensor is triggered by acidity from carbon dioxide.
Exactly the connection to make.
Right.
The brain senses this new acidity in the blood, assumes it must be from a dangerous buildup of CO2, and commands the lungs to breathe deeper and faster to blow it off.
That is wildly clever. So this artificially elevated breathing rate pulls much more oxygen into the system, which accelerates the acclimatization process.
Spot on. But if a patient ignores the AMS, takes a bunch of painkillers for the headache, and just keeps climbing, that throbbing headache can progress into the second of the big three, high-altitude cerebral edema, or HACE.
And this is where things get lethal.
Very. HACE is a true medical emergency. It represents a catastrophic breakdown of the blood-brain barrier. The brain literally begins to swell inside the rigid skull.
Oh, man.
And this swelling happens through two mechanisms, cytotoxic edema and vasogenic edema.
Okay, let's break those down because those are heavy terms. What is the difference between cytotoxic and vasogenic?
Well, cytotoxic edema means the brain cells themselves are swelling. Because of the severe lack of oxygen, the cells can't produce enough energy ATP to run the microscopic pumps that keep sodium out of the cell.
So sodium builds up inside.
Right. Sodium builds up inside the cell, and water always follows salt, so the brain cells bloat and swell.
And vasogenic.
Vasogenic edema, on the other hand, involves the blood vessels. The tight junctions between the cells lining the capillaries begin to unzip and fail, leaking fluid and blood plasma out into the surrounding brain tissue. You even see microbleeds in the brain.
So the cells are bloating and the pipes around them are leaking. The pressure inside the skull must be unimaginable. How does that present clinically?
The hallmark sign that a patient has crossed from AMS into HACE is ataxia.
Like stumbling.
Yeah, a sudden inability to walk a straight line or maintain physical coordination. And that's usually combined with altered mental status. They might become confused, hallucinate, or even become highly combative.
And if they aren't treated?
If that patient is not treated incredibly rapidly with immediate descent to a lower altitude, the powerful steroid dexamethasone to reduce the swelling, HACE progresses relentlessly to coma and death.
That's terrifying. And then there's the third major pathology, which completely bypasses the brain and just destroys the lungs. High-altitude pulmonary edema, or HP. The mechanics of this one are fascinating. The textbook explains it's caused by excessive hypoxic pulmonary vasoconstriction, or HPV.
That's right.
I want to try an analogy here to see if I have this right.
Go for it.
It's like the plumbing in a very old multi-story house. If you go to the basement and close off 90% of the valves to the pipes, but you keep the main water pump running at absolute maximum pressure, the water has nowhere to go.
Yep.
Eventually, the few open pipes are going to burst and flood the walls, or in this case, flood the alveoli of the lungs. The fluid literally leaks out of the capillaries under the extreme stress.
Your plumbing analogy perfectly highlights the mechanical failure there. If we connect this to the bigger picture, it also points to a tragic evolutionary misfire.
An evolutionary misfire.
Yeah, you see, hypoxic pulmonary vasoconstriction is actually a brilliant life-saving mechanism when you are living at sea level. Imagine you catch a localized lung infection, say pneumonia, in one small lobe of your left lung. That specific area becomes inflamed and poorly oxygenated, or hypoxic. Your body intelligently constricts the blood vessels in that specific infected area. It clamps the pipes shut to bypass the bad lung tissue, redirecting the blood flow to the healthy oxygen-rich parts of your lungs where it can actually pick up oxygen.
Oh, it's an automatic localized bypass valve.
Exactly. It's incredibly smart at sea level. But it becomes a deadly liability at high altitude because suddenly the entire atmosphere you are breathing is hypoxic.
So the entire lung senses low oxygen simultaneously.
Yes. So doing what it evolved to do, the lung commands a massive global constriction of almost all the pulmonary vessels.
Clamping down all the pipes at once.
Yes. This causes severe, widespread pulmonary hypertension. The blood pressure inside the fragile capillaries of the lungs skyrockets until they experience what the medical literature bluntly calls stress failure.
Stress failure, that sounds bad.
It is. The physical walls of the capillaries tear open under the pressure, leaking blood plasma and red blood cells directly into the air sacs. The patient essentially begins to drown in their own fluids.
Wow, and how do you treat that?
Well, beyond the absolute necessity of descending, clinicians use drugs like nifedipine, which is a potent vasodilator. It forces those clamped down blood vessels back open, dropping the pulmonary artery pressure and stopping the leak.
It's terrifying to think about, coughing up pink, frothy sputum on the side of a mountain because your own evolutionary defense mechanism ripped your lungs apart.
Yeah, it's brutal.
Now, AMS, HACE, and HAPE-PEL, these are acute illnesses that routinely strike down young, perfectly healthy, incredibly fit athletes. But if you are a clinical professional working today, you aren't just treating 25-year-old mountaineers.
Not at all.
Because of modern infrastructure, cable cars and high-altitude trains,
Yep.
you are constantly going to be counseling regular people who want to bring their pre-existing medical conditions into this highly hostile environment. Which brings us to a really complex area: the hidden dangers of altitude.
This is arguably the most critical area of modern high-altitude medicine. We are seeing much older populations and populations with significant chronic diseases taking a train up to 4,000 meters for a simple day trip. And the cardiovascular risks are immense.
I can imagine.
Let's go back to that immediate physiological response we discussed earlier. The 50% spike in cardiac output and the surge in sympathetic nervous system activity, the adrenaline and norepinephrine.
Right. So if you already have coronary artery disease, meaning the blood vessels feeding your heart muscle are partially blocked with plaque, that spike in workload sounds like a recipe for a heart attack.
It absolutely is. We call it myocardial ischemia. The heart muscle is suddenly beating much faster and pumping much harder, meaning it is demanding significantly more oxygen to fuel itself.
But it's demanding that oxygen at the exact moment the blood is carrying less of it due to the altitude.
Exactly. The heart starves. Sudden cardiac death, or SCD, is a massive, often underreported risk. The text notes a truly staggering statistic. Sudden cardiac death accounts for up to 25% of all fatalities in the Austrian Alps.
25%. 1 in 4 deaths up there isn't from falling or avalanches, it's from hearts just giving out under the hypobaric stress.
That's right.
So if I'm a doctor and a patient with heart failure asks if they can visit the Alps, my instinct is just to say absolutely not, stay at sea level. Is it really that black and white?
No. It requires careful individualized stratification. The medical community often uses the New York Heart Association, or NYHA, functional classification.
How does that work?
Well, patients with very stable, mild heart failure, those in class 1 or 2, meaning they are generally comfortable at rest and only get fatigued with moderate exertion, like climbing stairs, they can often travel to moderate altitude.
If they're careful.
Right. If they ascend very slowly and proactively, utilize systemic vasodilators under medical supervision. But patients with class 3 or 4 heart failure, those who are breathless just walking to the mailbox or even sitting in a chair, they should absolutely avoid high altitude. The environmental tax is simply too high.
And it's not just the heart that takes a beating, right? The gastrointestinal system undergoes horrific stress.
It really does.
The textbook cites studies of workers building the Qinghai Tibetan Railway, living and working at elevations between 3,500 and 4,900 meters. They also performed endoscopies on climbers at over 4,500 meters.
And the findings are wild.
Yeah, they found a shockingly high incidence of gastric and duodenal erosions and hemorrhagic gastritis. The mucosal lining of the stomach literally breaks down and starts bleeding.
Yes, because the cells lining your stomach require a constant rich supply of oxygen to produce the protective mucus that keeps your stomach acid from eating its own walls. The extreme hypoxia impairs that mucosal barrier.
That makes sense.
But what makes this particularly terrifying is the pharmacological interaction that almost always accompanies it.
Right, because what is a climber doing when they get a massive AMS headache? They are swallowing high doses of NSAIDs, like ibuprofen. Or they're taking dexamethasone to prevent brain swelling.
Precisely.
Mm.
Both NSAIDs and steroids independently increase the risk of gastrointestinal bleeding by interfering with stomach protection.
Oh, man.
Yeah, you combine those aggressive medications with a hypoxic environment where the stomach lining is already failing, and it is a recipe for a severe hemorrhagic event. Bleeding out internally while zipped inside a sleeping bag at 5,000 meters is a catastrophic medical scenario.
It's a nightmare scenario. And reading further into the sources, there are even more obscure risks, like high-altitude retinopathy, where you literally get hemorrhages in the blood vessels of your retinas,
Yeah.
or severe thromboembolic events, like deep vein thrombosis or pulmonary embolisms.
And that thromboembolic clotting risk is directly tied to the acclimatization process we praised earlier. Remember the body producing all those extra red blood cells to carry more oxygen.
Right, the extra delivery trucks.
Exactly. That is great for oxygen delivery, but packing that many cells into the plasma drastically increases blood viscosity. Your blood becomes incredibly thick, sticky, and sludgy.
Sludgy blood, great.
When you combine that thick blood with the severe dehydration and the extreme cold in the mountain environment, which causes your veins to constrict, you are at a highly elevated risk for forming massive, life-threatening blood clots.
The text even mentions isolated high-altitude psychosis, just a total terrifying break from reality, complete with vivid hallucinations induced purely by the altitude, completely separate from the brain swelling of HACE.
This is a very bizarre, isolated phenomenon, yeah.
Yeah. So what does this all mean? As a clinician, you are sitting in your office and a complex patient comes in. Let's say you have a 60-year-old patient with a history of peptic ulcers and stable angina, and they want to do a multi-day trek to Everest base camp. How do you mathematically weigh all these overlapping risks? Because you can't just look at their heart in a vacuum or their stomach in a vacuum.
This raises an important question, and honestly, it's the most difficult and nuanced part of pre-travel medical counseling. You cannot simply apply strict universal altitude thresholds like a blanket rule saying no one with angina goes above 3,000 meters.
Right, because it's too simplistic.
It doesn't reflect the reality of human physiology. The physician must evaluate a highly individualized clinical risk assessment framework. You have to calculate the combined metabolic cost of the altitude itself, plus the physical exertion required.
Like, are they riding a train or are they carrying a heavy backpack uphill for 8 hours?
Exactly. And then you add the pharmacological interactions.
So for that hypothetical patient, their angina means their heart needs more oxygen, but the altitude provides less, increasing the heart attack risk.
Right.
If they get an AMS headache and take an NSAID, their history of peptic ulcers, combined with the hypoxic mucosal damage we just talked about, puts them at critical risk for a catastrophic GI bleed.
Exactly. As a clinician, you have to look at that entire interconnected web of interacting variables and heavily counsel the patient on the severe compounded risks of that specific itinerary. You are managing the fragility of the entire human organism.
It's a delicate, high-stakes balancing act of human biology pushed to its absolute limits. We've covered a massive amount of ground today. To briefly summarize the narrative of our clinical journey, we started with Torricelli and the physical laws of barometric pressure, understanding that the scarcity of oxygen molecules, the low partial pressure, is what drives all this pathology.
We then looked at the body's acute hemodynamic responses. That immediate, desperate 50% spike in cardiac output, which serves as a bridge until the slower, long-term production of new red blood cells can take over.
Right. And we explored the pathophysiology of the big three when that acclimatization fails, the debilitating headaches of acute mountain sickness, the lethal, brain-crushing swelling of high-altitude cerebral edema, and the catastrophic plumbing disaster of high-altitude pulmonary edema.
And finally, we navigated the incredibly complex management of pre-existing medical conditions, from ischemic hearts to bleeding stomachs in these hostile environments.
Now, as promised for our medical learners and the insanely curious alike, we want to leave you with a quick clinical review question to really reinforce this material. So picture this scenario.
Okay, set the scene.
You are the medical officer stationed at a base camp at 4,000 meters. A patient stumbles into your medical tent. They have a severe, throbbing bilateral headache that significantly worsens every time they cough. They are experiencing extreme fatigue and severe nausea. However, when you listen to their chest, their lungs are completely clear, they do not have a cough, and they are not experiencing shortness of breath while sitting still. Based on our deep dive today, what is your primary diagnosis and what medications should have been considered beforehand to speed up their acclimatization?
We'll give you a second to think through the symptoms and the specific negatives.
Okay, the answer is acute mountain sickness, or AMS, and the standard prophylactic medication you'd consider is acetazolamide.
Yeah, and the total lack of a cough or shortness of breath at rest helps you rule out the fluid buildup of APE.
Right, and the lack of ataxia or confusion points away from the brain swelling of HACE, leaving us with the classic cardinal features of AMS.
It's all about recognizing those specific clinical boundaries and intervening before the patient crosses over into life-threatening territory.
Absolutely. To wrap up, I want to leave you with a provocative thought, something to mull over on your own that builds on everything we've discussed today.
Okay, let's hear it.
We spent a lot of time talking about how the human body adapts by churning out massive amounts of red blood cells and how that can lead to dangerously thick, sludgy blood.
A condition that can eventually cause heart failure, sometimes called chronic mountain sickness.
Right. Yet there are indigenous populations in the Andes and the Himalayas who have lived at extreme altitudes for thousands of years. And researchers have found that they have specific, evolved genetic adaptations that allow them to thrive without these pathological responses.
Yeah, their bodies don't wildly overreact by overproducing hemoglobin.
Exactly. So as the field of genomics rapidly advances, could we one day use targeted therapies to temporarily activate those exact same genetic pathways in unacclimatized lowlanders? Could we essentially turn off altitude sickness at the cellular level before a climber even steps foot on the mountain?
It is an absolutely fascinating frontier. The transition from merely treating the downstream symptoms of hypoxia to actively reprogramming our fundamental genetic response to it. I mean, that could revolutionize not just mountain medicine, but how we treat critically ill, oxygen-deprived patients in ICUs worldwide.
It's incredible to think about. Thank you for joining us on this deep dive into the sources. We hope this exploration of high-altitude medicine has equipped you with new clinical insights and a profound respect for the ocean of air we live in. Keep questioning the consensus, keep learning from the extremes of human survival, and most importantly, stay curious.